discuss them in detail. Next, I invite Lohith, one of our colleague uroradiologist, and Lohith is a good friend and also a very kind of academic person interested in presenting the MRI of the prostate to the trainees and to the trainees' understanding. He's going to discuss with us how a urologist can look into the MRI scans and also how it can be used for surgical planning. Welcome, Lohith.
Thank you, Anand. Thank you for the introduction. Let me share my screen now. All right. Firstly, I'd like to thank iTrue and UroGRIPP team for giving me this opportunity. So this talk is about the basics of multiparametric MRI, prostate, and how it helps in the surgical planning. So I understand most of the audience members are urology trainees or urologists, and I'm not expecting radiologists here, maybe a few. So this talk is going to be quite basic, and we'll go through lots of sample cases and how it helps in surgical planning. So coming to the scan itself, patient selection. So that's up to the urologist, after clinical examination, PSA value, DRE. They are then referred for an MRI prostate. Sometimes we even do MRI prostate after biopsy, but it is recommended we do MRI after 6 to 8 weeks of biopsy to avoid any post-biopsy hemorrhage, interfering with the interpretation of the exam. And sometimes we even do follow-up MRIs as part of active surveillance. Now, preparation, there is a bit of preparation prior to the scan. Usually antiperistaltic agents are administered prior to the scan to reduce bowel peristalsis, to reduce the artifacts. Some centers even perform a limited rectal enema, even if they're not introducing an endorectal coil. That is because air in the rectum can produce artifacts in some of the MRI sequences. Yeah, and obviously contraindications for MRI have to be checked, which is deemed mandatory. So now coming to the scanner itself, we can perform this on both 1.5 and 3 Tesla scanners. Obviously 3 Tesla is a better option. And we can use endorectal coils or body coils. So body coil is placed over the lower abdomen, whereas an endorectal coil, as the name says, it's introduced endorectally. Now, so the choice of scanner, choice of coils, the best scanner would be 3T, and the best coil combination would be using both endorectal and body coil. The next best would be using endorectal coil with 3T, otherwise just a body coil with 3T. Then, which is, if you're using a body coil with 3T, it is equivalent, almost equivalent to using a 1.5 Tesla scanner with an endorectal coil. And most of the practice in the UK and even in the Indian subcontinent, where I worked previously, is mainly body coil on 3T or high-end 1.5T scanners. So which is good, which gives us good information for surgical planning. But again, if we have endorectal coil and if it's a high-volume center, I think that would give us, the most accurate, most useful images here. Now, with regards to the scan, with regards to the sequence itself, there are 4 sequences that we perform in all multiparametric MRI scans. T1 and T2 are techniques. T1 and T2 sequences are techniques to evaluate the morphology of prostate and the adjacent structures. DWI and ADC are part of functional imaging techniques, along with a dynamic contrast enhancement study. So here I've mentioned DWI and ADC, which stand for diffusion weighted imaging and apparent diffusion coefficient. These are not 2 different sequences. We perform DWI with multiple B values. I'm not going to go into the technical aspects of diffusion weighted imaging, but just let me say that there is a lot of technical specifications that have to be right to perform the sequence. And once we perform DWI, we get ADC as a map, as another sequence, which is extrapolated from the diffusion-weighted sequence. So we are going to get multiple sets of images when we perform diffusion with multiple B values. And we also, some centers, I guess, high volume centers and research oriented centers perform MR spectroscopy and diffusion tensor imaging, which we are not going to talk about because it's not commonly used. It's not used in clinical practice at present. Now, what do these sequences help us in? So T1 sequence mainly shows us hemorrhage if there is any hemorrhage. And it also gives us an overview of the general anatomy. We can pick up lymph nodes. We can evaluate bone marrow. T2, I would say this is the most important sequence in terms of delineating the zonal anatomy, measuring the prostate size, even identifying signal alterations, which would indicate pathology. And then we take the help of diffusion-weighted imaging and dynamic contrast enhancement study to further characterize what we see on T2 and see if that actually correlates well with the likelihood of cancer. And diffusion has a high negative predictive value than T2. So once we find a signal alteration on T2 sequence, we then look at DWI and then go on from there and use PIRADS scoring to find out the likelihood of cancer. Now, so we've talked about the 4 sequences. We'll see sample images of how they look. Now, T1 and T2, we do multiple T2 sequences, high resolution, small field of view sequences, but we perform only one T1 sequence. And as I said, T1 is mainly to look at the hemorrhage and maybe a general overview. And most of the morphological imaging is gathered from high resolution, small field of view T2 sequences. Now, how do we identify which is T1 and which is T2? We can look at the urinary bladder here. Urine is bright on T2 weighted images, whereas on T1 it is dark. So that's one way to easily identify which is T1 and T2. You can see these seminal vesicles, small tubules containing fluid inside, which is bright here, whereas it is gray or dark in T1 sequence. Now, I've been using the words bright and dark. We report them as hyper-intense and hypo-intense on our reports. We also have iso-intense, which is in between, or we take neighboring structures as a reference to call something iso-intense. Now, bright and dark, hyper-intense and hypo-intense, I will be using them interchangeably throughout the presentation. Now, this is T2 weighted sequence, axial plane of a normal looking prostate gland. You can see the central gland, which is darker than the bright, homogeneous, normal peripheral zone. So this is the normal signal of peripheral zone. It is bright on T2. That is how it should look like. And central gland can look quite heterogeneous, and that in fact is one of the limitations of interpreting transition zone lesions, which I will talk about later. But again, transition zone, so the appearances are varied because of the components, right? The stromal component gives dark signal, whereas the glandular component, which has more fluid, gives a bright signal. So here in this case, there is a lot of stromal component. That's why you have lots of dark areas. Maybe these bright areas refer to the glandular component of the central gland. Now, this image is a DWI image, and this is the ADC image on the left. Now, there is a small bright focus on diffusion-weighted imaging. So on DWI sequences, we are looking for bright lesions, which are the abnormal ones. On ADC, it will be the inverse of what we see on DWI. So if it's bright on DWI, we look for a dark spot on the ADC images. So you can see that there is a small, significant lesion in terms of diffusion restriction. Now, this image, you can see that the bladder, the urine in the bladder is dark. So this is a T1 weighted sequence. And this is a post-contrast sequence. You can see contrast in the ephemeral vessels. And you can see that only the right half of the prostate gland is enhancing. That is early enhancement in a dynamic study, and this is significant. This would be a positive dynamic study, and we would then look at the diffusion and T2 to figure out if it's a high-grade Peyer's lesion. And even the fat is dark. That is because we are using a fat-saturated sequence, T1 sequence for post-contrast studies. Now, this is the sector map provided by the ACR Peyer's version 2.1 document. It is freely available, open access. So some radiologists use the sector map to localize where the tumor is, draw it, and attach it to their reports. But the reason I'm showing it to you here is a couple of things. Especially this green part, the central zone, because the latest version of Peyer's talks about central zone lesions, and also this anterior fibromuscular stroma lesions in these have been given certain importance in the latest Peyer's version. Now, other than these, I would also like to focus on the ejaculatory ducts and the prostatic urethra. So ejaculatory ducts at the base are quite posteriorly located, and as they move anteriorly, they merge with the urethra in the mid-gland level. And in the lower third of the prostate, we do have urethra and periurethral sphincteric tissue, which we can see as a bit of thickened brown colored representation here. Now, so we will see how we find this on an MRI. So this is a T2 weighted axial sequence, and so these are the ductus deferens on either side. They will merge with the medial ends of the seminal vesicles. They've merged here. And these are the seminal vesicles on both sides. So that's in the midline. Now, these are the ejaculatory ducts, which are somewhere here. And this is the enlarged central gland, enlarged transition zone. So this patient has BPH, a bit of trabeculated bladder, but we are focusing on the central zone here. And we've reached the base of the prostate gland, and as I go down, we will get to see the peripheral zone, which will be bright. So this is the peripheral zone, which is the bright area on T2, and this is the central zone, which is quite apparent. Central zone has a lot of stromal component, that is why it looks darker. And you can see the transition zone containing glandular elements and stromal elements, bright and dark areas. So now as we move on, so that's the central zone, and as we go down, we see the peripheral zone clearly, and the central zone narrows at mid-gland level, merges with the urethra. That's the prostatic urethra, small bit of bright signal here, and we are reaching the apex, and apex contains only the peripheral zone. So apex is surrounded by, so this entire bright area surrounding the urethral sphincter, that's the urethra, surrounding it is the apex. Now, the same thing I'm showing it to you on a coronal plane. That's the trabeculated bladder. It's of the same patient. You can see how it's protruding into the bladder neck. And so that's quite a huge prostate. And so as I can show you the ductus deferens that's coming up there, it will join with the seminal vesicles. Those are the seminal vesicles, and that's the central. So that's the central zone, which is like an inverted cone. That's the peripheral zone. Yeah, so we will move on to, so we've appreciated how the anatomy looks. And now, so I'm not going to go into the details of how Peyer's is scored. Let's leave it to the uroradiologist to score that. But we will see how a urologist can interpret an MRI. Let's take a hypothetical scenario where you don't have access to the report and you have to find out where the lesion is, and you have the MRI with you. So you know that it's a high-grade Peyer's lesion you're looking at. So you're basically looking at a hypointense, a dark area on T2 weighted images. And that same lesion will show diffusion restriction. So it will be bright on DWI and dark on ADC, and it will show early enhancement on dynamic contrast images. Now, this would indicate likelihood of a prostate cancer, and based on the severity of the signal changes and diffusion restriction, we have different scores given to them based on the pattern as well. Now, on the left, this is a beautiful representation of what sequences we use for a lesion in a particular zone. So in the peripheral zone, so I'm going to use DWI as the main sequence to give a PIRAD score. And if we have a DWI PIRAD score of 3 and that lesion shows positive dynamic contrast enhancement, we upgrade it to PIRADS 4. So the overall score will be 3 + 1, 4. Likewise, transition zone, T2 weighted imaging is the main sequence to provide PIRAD score, and we take the help of diffusion weighted imaging to upgrade it if there is a high DWI score. And you can see here, high DWI score then goes to PIRADS 3 from 2, and likewise for 3. Now, so we've seen what kind of appearances prostate cancer will have, and how it will help is what I'm going to show you in the next few slides. But we need to talk about a few limitations of the MRI. And so we've been talking about post-biopsy hemorrhage. So 6 to 8 weeks after biopsy, MRI is recommended. We have to wait till then. And sometimes inflammation can masquerade as malignancy. And when there is a diffuse change, we should suspect background prostatitis or a prostatitis with a lesion which is hidden underneath. So we might have to do a follow-up scan. So that's one of the limitations. And again, transition zone, owing to its heterogeneity, it might be difficult, especially for a general radiologist. And small cancers in transition zone are difficult to interpret, even for the specialists. Now, air in the rectum can cause artifacts, especially in diffusion weighted imaging. So some centers prefer performing a limited enema. Now, so there is a definite interreader variability in prostate reporting, especially when it comes to small lesions and the transition zone lesions. And nodal involvement with the present multiparametric MRI, it is quite, it lacks sensitivity quite a bit, and although specificity is high. So there are a few research studies using other tracers to find out positive lymph nodes, but they have not come into clinical practice, and we are not going to talk about them now. So let's see sample cases. This is a classic BPH of 3 different patients. In this case, you can see a very well encapsulated nodule in the right transition zone. You can see a very dark, clear dark capsule. So this is a very well encapsulated typical BPH nodule. In the image in the middle, you can see a fairly homogeneous, well circumscribed nodule, but I don't see a dark capsule here. So this is a typical nodule, but it's still categorized as PIRADS 4. Now, this is quite diffuse. There is a diffuse background stroma, which is moderately hypointense. There are no suspicious very dark lesions. So this is also BPH without any obvious suspicious foci. Couple of more BPH images. This is in the sagittal plane. This is slightly off the midline, where you can see a bit of bright peripheral zone, some bit of seminal vesicles. You can appreciate how it is pushing into the bladder neck. Now, this information is quite useful for the surgeon when they're dissecting the bladder base. Now, in this another BPH, you can see the ejaculatory duct very well, and this is the area of the verumontanum. You can appreciate the urethra, and you can provide measurements, the mid-urethral length, the membranous urethral length, which some studies have found that the length of the preserved length would indicate post-surgical continence, and so we can give you measurements on the MRI. Now, so we've seen a benign condition. Let's move to lesions and their PIRAD scores. This is a classic PIRADS 2, very low suspicion of malignancy. Peripheral zone is bright, but there is very mild, very ill-defined reduced signal, and there is no obvious discrete bright focus on diffusion-weighted imaging. ADC does not show any dark focus, so this is a PIRADS 2. And moving on, this is a PIRADS 3 area in the left posterior peripheral zone, and quite ill-defined margins, maybe slightly heterogeneous, and on the diffusion-weighted imaging, I can see mild diffusion restriction and maybe mild to moderate dark signal on the ADC. Now, we do have, severity of diffusion restriction. In a semi-quantitative manner, we can assess based on the signal intensity values, and I'm not going to go into the specifics of it, but here you can see non-circumscribed lesion in the peripheral zone, which is not too dark and it's not restricting too much. So this would fall into PIRADS 3. And when we see higher grade PIRADS 4 and 5, you will understand how dark the high grade ones look. Now, another similar example, there is a right-sided, non-circumscribed heterogeneous T2 hypointensity showing mild diffusion restriction, and this would be PIRADS 3. So we can talk about the dimensions of the lesion, how it is, it has a broad area of contact with the capsule, but the capsule looks intact. So we can give you additional information on those other aspects of the lesion. Now, this is a small 1 centimeter dark T2 lesion, which shows bright focus on DWI, which is dark on ADC. And this is one of the phases of dynamic contrast enhancement. So this lesion is enhancing, whereas rest of the peripheral zone is not enhancing. So this is enhancing early along with the BPH nodules. So this, with T2 diffusion, would be a PIRADS 3 lesion because of moderate signal and moderate diffusion restriction, and gets upgraded to 4 because it shows it is positive on dynamic contrast enhancement. So that would be PIRADS 4 lesion. So that's where it is 3 + 1, 4. Now, another PIRADS 4 lesion, left posterior dark lesion, which is quite bright on DWI, quite dark on ADC, and shows early enhancement. You can appreciate the enhancement very well. Rest of the peripheral zone is not enhancing. So this is a PIRADS 4 lesion. And the only difference between PIRADS 4 and 5 is actually the dimension of the lesion. Less than 1.5 centimeters would be PIRADS 4, greater than 1.5 centimeter would be PIRADS 5. So this is a very large PIRADS 5 lesion involving the right half of the gland, invading the transition zone as well. You can see it's very bright on DWI, very dark on ADC, showing early enhancement on contrast enhancement. So this is a PIRADS 5. And there is some bit of thickening of the neurovascular bundle here. And that is a finding that we have to report, and surgery would be planned based on sparing or resecting the neurovascular bundle. And this is another PIRADS 5 lesion, lenticular lesion in the right half of the gland, and you can appreciate dark on ADC, bright on DWI. So that's another Pyrites 5 lesion. And there is the prostatic capsule looks quite smooth and intact. So neurovascular bundle, I don't think there is any extracapsular extension if the capsule looks intact. Now, let's see another case where T2 weighted imaging, bright peripheral zone. Now there is a lesion here and the prostatic capsule is actually deformed and there is a small amount of lesion outside the capsule. And that's where you can see small gray bits of neurovascular bundle. So it is actually transgressing the capsule and is invading the neurovascular bundle on the right side. So you can see how the capsule is notched like this, probably because of desmoplasia there. Now you can appreciate that on the coronal view. This is the capsule and this bit of tissue is outside, and all these structures are part of the neurovascular bundle. So the lesion is involving the right side of neurovascular bundle. Now, now the lesion is here anteriorly. This is a typical prostate, a BPH nodule with a capsule. Now, anterior to that, you can see a lesion in the transition zone. And this dark band is the anterior fibromuscular stroma. Anterior fibromuscular stroma looks dark on all sequences. Now, this is slightly grayish as compared to the dark anterior fibromuscular stroma. And now you can see that this area is normal, and whereas this AFS on the right side is thinned out because this lesion is involving transition zone and a part of anterior fibromuscular stroma. And this is the anterior periprostatic plexus of veins and other neurovascular structures. So the anterior fibromuscular stroma is not breached. I can still see a dark line. So I'm just going to say that it is located anteriorly, but it hasn't gone beyond the confines of the prostate. I can see that it is bright on DWI and dark on ADC. So that's a Pyrites 5 anterior lesion. Now,
Lohith, you have another 2 minutes, Lohith.
Okay, so we're going to see quickly another anterior lesion. That's going beyond the anterior fibromuscular stroma, so into the retia space, retropubic space. So that will help decide how the dissection goes for the surgeon. Now, another Pyrites 5 lesion at the base on the left side, bright on diffusion, dark. And you can see how it is involving the base, medial end of seminal vesicles, a bit of central zone. So, so it is also going beyond the confines of the prostate here, so there is some bit of extracapsular extension. Another similar Pyrites 5 lesion on the left side. This is close to the apex, so so this is a peripheral zone, normal peripheral zone surrounding the apex. This is the abnormal lesion, and you can see how it is showing diffusion restriction and showing early enhancement on contrast studies. Now we have seminal vesicle invasion can be figured out on MRI. So that's at the prostate base, that's the lesion that's involving the left seminal vesicle and a bit of right seminal vesicle. So you can appreciate diffusion restriction, that's dark on ADC and that's enhancing. So this part of seminal vesicles, both sides and the base, they're all enhancing. So that's lesion causing seminal vesicle invasion, both sides. This is a lesion at the prostate apex, and it is it's the fat planes between the neighboring structures are all lost, so we have to be careful. And so this is where this section is from, and so apex is one of the important areas for the surgeon to know and to provide adequate margins for dissection. Now, so all these examples show how MRI can help in surgical planning. We can locate the tumor. We can tell you if there is frank neurovascular bundle involvement, or there is suspicion, or it is clear of the capsule and the neurovascular bundle, seminal vesicle invasion, extracapsular extension. All these can be figured out with a high degree of confidence, and information about where the surgical dissection needs to be carried out, because based on the location of the tumor. We can also give you information about how the median lobe is protruding into bladder neck. Incidental findings can be picked out on MRI. And some studies have talked about finding, evaluating pelvic size to look at how difficult the surgery could be for the robotic arms. The amount of space available in the pelvis for the robotic arms can be kind of determined based on the pelvic size. And ACR PIRAT's document is an open access document. It has got the entire technical specifications, lexicon, few sample images, sample report, everything is available, open access. Please do have a look. Thank you.
Thank you, Lohith. That was a very nice presentation, and we can see a lot of hard work was there during the slide preparations, and I'm sure this will be a very good learning resource for the trainees to prepare for their exams, and also the practicing prostatectomist to plan the surgery also. Thank you very much.